off you go.
Hello, ladies and gentlemen. I hope you're all well. Well done for the massive reaction, very quick reaction in discussing tonight TTP, but primarily in association with COVID, which obviously is quite topical at the moment. I've seen the questions that have come through, but firstly, can you all hear me okay? Thumbs up. I can only see 3 people on the screen. I've got a thumb. That's a nice thumb. Good, as long as you can all hear okay. I've put a few slides together, and one to explain a bit about COVID as much as we understand it, and 2 that hopefully will answer some of the questions that I got through. Let me tell you, I was very impressed with the questions. There are medical colleagues that don't ask as many sensible questions. They were really very, very cool. So the first thing to say, although it's an awful period for everybody, not just in the UK, but internationally, we must be mindful that the majority of cases of COVID-19, which is a viral infection, you will not come in contact with the hospital. You just won't come in contact. So on this chart, can you all see the screen? Yeah. So it's only really a very, very small percentage of patients that end up as critical cases. The vast majority in the UK are down here. They've really not been diagnosed because obviously there was a delay in getting the equipment and the reagents through to be able to do testing, which is different now. And most people in the population will have had mild symptoms or not even know that they've had COVID-19. So really the overall percentage of patients who are critical or have severe disease is only very, very small in the total population. Now I've got to, oh, there we go. So this is a slide that similar to ones that you will have seen before looking at TTP. So essentially we've got these big long proteins called von Willebrand Factor, and von Willebrand Factor is important in COVID, so that's why I'm going over it again. And we have ADAMTS13, which you all know about, I'm sure. And that breaks down the von Willebrand Factor into smaller fragments, which bind with platelets. So that's what we want to happen, so that if you have a damage in any of the cells, either externally or internally, they plug the damage. So in TTP, where we know there's an absolute deficiency, so really low levels of ADAMTS13, it can't break down the big long strings, and we get more platelet binding. And these break off and cause the problems and symptoms that many of you will have had if you've had an acute episode. So COVID-19 is slightly different. So I think one of the hypotheses, and it is an hypothesis because nobody actually knows what's happening in this condition. We know what we see clinically, but it is not like a condition that we've been exposed to, many of us, in our relatively long medical lives. So we think that the virus affects these cells lining various organs, structures, and that releases what we call cytokines. And these are products from the cells that are released with any damage. So they will be released normally. So TTP patients have high levels of these cytokines, and we already know that, but it's not necessarily relevant because we also know what the underlying problem is that we need to treat. And these cytokines, as well as activation of many other systems, so the immune system and the coagulation, the clotting system, this becomes too overactivated in the very, very severe cases, which will and can result in small blood clots being formed. In COVID, it's primarily in the lung. That's the main organ that's damaged. And it's not like the blood clots that we see in TTP. There are platelets there, but there's other cells, so there's inflammatory cells there. So there are differences, significant differences, but there are some similarities, and that was some of the questions that was posed that I hope by the end of this will make a bit more sense. So here I've just taken this from Google. You'll be able to find this anywhere. So we've got the COVID, the SARS virus, which primarily affects the lungs, and it mainly enters those endothelial cells that I showed you a minute ago by this receptor, which has got nothing to do with TTP. We then know that there's all these cytokines, these inflammatory components that are released, and that activates the immune system, similar to TTP, but similar to many conditions, many conditions, not just TTP. And then you either improve because your immune system starts activating itself against the virus, or there's that small percentage of patients who do not improve immediately and need to go to hospital and can end up with a number of organs that are affected. So one of the ways to look at this condition is, unfortunately, at post-mortem samples, and this is some histology, not from the UK, from elsewhere in the world. And what they identified early on, which is probably why we've had some of the questions, is these little thrombi, but mainly in the lung. There is some in the kidneys, there's a suggestion in the heart, but they're not like you see in TTP. But they are little thrombi affecting the arterioles in the lungs in COVID-19, but along with a whole load of other inflammatory changes. So they do not look like the blood clots that we get in TTP. They're quite distinct and separate. But still, the underlying kind of what we call the pathogenesis, the cause, one needs to consider the similarities. So I've tried to think about how there's similarities or differences between TTP patients and COVID-19, because it was one of the questions, or few of the questions. So the sex differences between the two conditions, particularly in patients that have severe disease. In TTP, we know that 70% of patients are female. That's the same worldwide. In COVID-19, it's more likely to affect men than women. So what's the risk of developing TTP? Well, we don't know in the majority of cases. It's an immune-mediated condition, happens out of the blue, and we don't know what stimulates it. However, the risk in COVID-19 is having chronic conditions such as heart disease, diabetes, or chest conditions. What are the organs affected between these two? So in TTP, it's mainly the brain and the heart, and sometimes the kidney. In COVID-19, it's quite different. It's almost 100% the lungs, but the kidneys, heart, and brain can be affected. So what's the age distribution? In TTP, it primarily affects women between the ages of 30 and 40. So let me show you what's just been released from New York, which I think is quite good to understand. So the risk in the age group that we normally see TTP with regards to death is very low in the comparable age group, and it increases with age. So the highest risk are the elderly, which we've known for a long time. But then if you look at the number of patients with or without underlying medical conditions, you can see the vast majority of patients that are affected and actually who die have underlying medical conditions. So is there a risk of blood clots between these two conditions? The answer is yes, absolutely. So in TTP, the little blood clots. In COVID, we're seeing the little blood clots, which are not the same as TTP, but primarily in the lungs. But they also have a much higher risk of bigger blood clots, so in the lungs, in the legs, in the arms, and sometimes there are strokes or heart attacks or funny rhythms of the heart. So what's the underlying cause between these two conditions? Well, we know in TTP it's ADAMTS13, it's very distinct. And the underlying cause in COVID is not known. We know it's the virus, but what causes it to be so severe in a very small number of patients is yet not known. So there was also the discussion, some of the questions about plasma exchange. In fact, the plasma exchange is to get plasma from patients who have had the virus and have formed antibodies. So generally it's taken from the arm and not plasma exchange, but you can plasma exchange some patients. And what we do is take away the plasma that has antibodies to COVID-19. And the hope is that by giving this to patients who have the infection, or in most of the trials that are going to happen, it's going to be in the really, really sick patients, it will help the immune response and reduce the effect of COVID-19. Now, the availability of this convalescent plasma, certainly in the UK, is actually only under clinical trials. So there's 2 big clinical trials that have or about to start where the plasma is going to be given to patients. And ultimately, if it works, it will be available more widespread. And the reason for doing it is from work in the China, Southeast Asia region, where they gave convalescent plasma to patients. And the red line is the inflammatory markers, which dropped. And the blue line is called the PF ratio, and it's basically the respiratory function of the patient. So the higher, the better. So this was obviously a very sick patient with a low PF ratio, and after the convalescent plasma, it improved. However, it's not good enough just to give it to 1 or 2 patients and see a response, because they're getting multiple therapies. And that's why it's so important it goes through clinical trials to make sure it isn't just by chance. So these were some of the outstanding queries, but I'm really more than happy to discuss this in more detail. So one of the queries was, is patients with autoimmune disease at increased risk of getting COVID? There is absolutely no evidence for that. So the risky groups are the ones that are discussed by the government, but also that I've discussed today, so more chronic conditions. So TTP is not chronic per se. You have acute episodes where the antibody levels will be high and then they're treated. The chronicity comes in follow-up. However, immune deficiency is potentially an increased risk factor, and that's why patients who have had chemotherapy or recently had high-dose steroids, and indeed we put patients that have had rituximab, we ask them to just self-isolate for 12 weeks, just to be on the safe side. But is rituximab a risk for developing COVID-19? I'm going to throw that back to all of you. When you had rituximab, do you remember getting loads of viral infections after having rituximab? The majority do not. And the risk of getting viral type infections usually is because of high-dose steroids, which can increase the risk. However, we have to be cautious. We still are treating patients who need to have rituximab as an outpatient to prevent a relapse, and we put them into the 12-week isolation bracket. So is plasma exchange being used to treat patients? The answer is no. It's plasma, convalescent plasma, and it's usually plasma infusion, not plasma exchange. However, we have been using plasma exchange with Optiplas, the type of plasma we use in the UK, for patients with severe COVID-19, not because they've got TTP, but because we want to reduce the inflammatory markers and reduce the thrombotic risk. But that's a sideline and it's a secret. And if I hear it coming out in the public domain, I'll know it's you lot. So we need to publish this and we need to do a proper trial. Is plasma safe? So the plasma that they're going to be using within the UK, the convalescent antibodies to COVID-19. Well, the National Blood Service is collecting the plasma. They don't treat the plasma the same way that we use the plasma that we use in plasma exchange in the UK. So we use solvent detergent, which is treated to prevent against reactions. But the NHSBT do check for other types of pathogens. So it's as safe as it can be. It's important that they have an adequate antibody level to the virus so that it will have effect in patients. But as I said, that will depend on what comes out of the clinical trials. The next thing, which is very topical, is vaccines. So the trials for the vaccines are just starting this week. So they're going to vaccinate thousands of healthcare workers, and it's going to be randomized. So some will get the COVID-19, and other will get what they call a dummy type vaccine. And they need to see if it's going to be effective before we give it out to the public. Can you get vaccines as a patient who's had TTP? The answer is absolutely yes. But if you've had rituximab in the last 6 months, it may be that it will not be effective. So we look at another marker called the CD19, which is the number of B lymphocytes, the ones that produce antibodies. And once we see that increasing, or if it is in the normal range already for those that had rituximab some while ago, it will be effective for you. And there's no suggestion it's going to cause a relapse. Vaccinations don't usually, but we will of course be cautious. I think that's it. Joe, I need you to remove that screen. I don't know how you do it. And I'm more than happy to take any questions, particularly any worries that you've had over this intervening period. I suppose the one that everyone's going to ask is, am I at risk? If you have a normal ADAMT13, which the majority of you I'm sure will have, you are at no increased risk than the general population. Obviously, the caveat to that is if you've had recent treatment, we would want you to self-isolate for 12 weeks. So I'm going to stop talking there and take any questions at all.
We've had loads of thanks, Marie, on the chat that you can see because you're a co-host. So hopefully you get a chance to look through that.
Yeah.
So do want to thank you so much for offering to do this.
It's my pleasure. You mustn't be worried.
It's been brilliant. Oh, someone's tapping the screen. And so just want to tell everybody about two things really. We've got another event coming up on the 9th of June, and that is with Dr. Tina Dutt from Liverpool, and that title of that is Living with TTP, Acute and Longer Term Neurological Complications. And we will be advertising the link to book onto that over just as soon as I've slept and got a chance to get back on and log it in. And the other thing I'll be doing is emailing you all with an evaluation just to ask how you felt this went and whether this is something we can do on a more regular basis. So really just want to again thank you, Dr. Scully, Professor Scully, for giving your time this evening, but also for arranging for the UCL charity to pay for the Zoom platform so that we could open it up to more than 100 people. And we've had 110 people come. We had 134 booked on, but I haven't had any messages. I think people maybe just have forgotten, but it's been brilliant. Thank you, Marie.
We'll have to have more, won't we? Because we booked it for a year.
Definitely. Definitely. Thank you so much. Take care, everyone. Bye-bye.